Thank you very much for the invitation and for the introduction. I hope to copy with your expectations with my presentation. So, what I'm going to talk about? I'm going to talk about the world of apps that everybody is aware of. But I will try to tackle it from different points, both the user point of view, which is the citizen, the patient point of view, and the physician point of view. So first of all, why these apps can be important? Because we all know that we are standing a demographic change that will switch the old age dependency ratio, meaning the ratio between people working and people not working, from about 28% of now to 50% in 2060. And what are the consequences of this? Of course, we are going to live more, which is good, but now there are 4 people working for 1 retired. In 2060, there will be 2 people working from 1 retired. What this does mean? This means that we will retire at 74. This is what will be the age if we want to keep the ratio of 4 to 1, which means to have resources to pay retirement plans to everybody in Europe. This is a reality. So, the other reality is that based on this age increase, the expected expenses for healthcare and long-term care are going to increase by 2% of the European GDP, which, if you compare to the GDP of your country, is already a lot of money. But if you consider this as European GDP, is a higher lot of money. You can think of it. So we know that, due to these figures, that the delivery of care with fewer resources, because there is not this 2% to invest, is considered to be a major political challenge, and the care system is in great need of innovation. So one way to innovate is the concept of an ideal patient-centered care approach, which includes the fact that patient is empowered, so patient is able to provide self-management, shared decision-making with the physician, and coaching from the physician. But patient empowerment, despite the fact that has become a key priority, is not giving nowadays the results of this process. Why? First of all, there is a lack of consensus, even on the concept. What does it mean, patient empowerment? Multiple meanings and use of these terms, according to the stakeholder which is pronouncing the word of empowerment. Difficult in putting together evidence-based data that can sufficiently enable policy decision makers to scale up solutions from little pilots to general population solutions. So, a lot of terms can potentially say the same things. I want to try to define what is patient empowerment for me and what I'm trying to deliver as a message to the cardiology community, which is the one which usually I try to talk to. Are these terms just synonyms of the same concepts, or they mean different things? So I just show you results of this study of some Italian colleagues of health economics. They made a review of a literature in which they examined the terminology that were used in papers. So you can see in these 286 papers, different terms were used, not all the same terms. In the majority of studies, there is no clear definition. So use the terminology without defining it. In other studies, there was an unclear definition. So there was some definition, but not so clear, or relationship with other concepts that we're using in the same article. So if you look at for empowerment, for example, we have 64 studies, 58% no definition, 33% with little definition, which means only 9% had a clear definition of what empowerment is. And also, health-reported outcomes is a minority of what is related to this terminology. So there is a problem until people are not talking the same language. And to create the same language, I will base on the same study, because I think that gives a good definition. Of course, you can like other definitions. This is what I intend for when we talk about enablement, empowerment, and engagement. So enablement has been referred to the giving the tools, the knowledge and skills for meaningful self-management. But this doesn't imply necessarily sufficient motivation. So when we're talking about digital literacy, health literacy, as the session that will follow me, we are talking more about the enablement part. Then engagement, instead, is the part that changes to modify your behavior, giving you motivation. But this doesn't necessarily mean that you have the ability and the skills to do self-care. And empowerment actually is the combination of these two concepts. So you have the tools and you have the motivation in order to participate in your decision-making. And of course, we are talking about emergent state here, so we are not even acting. When the action is taken, then we are talking about participation and involvement. This is the behavioral state, which results from the mental state, which comes before. So before you take the decision and after you make the action. And so we are talking about participation and involvement. So we said that in order to improve health, we have to try to find a way to change behavior, in particular if we think about prevention. And this needs that we need to change the mind. So for example, if you have a predisposition, you think that doing exercise is good, but you don't have the skills, you don't have a motivation, you will never do it. But if somebody gives you the skills and try to guide you in the motivation, you're going to end up changing your behavior, doing physical activity, which results in improved health. And in order to change the mind, what can be done is acting with behavior change techniques, which are actually general techniques to try to persuade you to change your behavior. And this is psychology, fundamentally. And this also related to technology. So why engineers and IT people and computer scientists come into the game? Because we are talking about making a technology persuasive. Persuasive technology refers to the fact that you can use IT solutions in order to deliver a persuasion message, to try to change behavior, attitude, motivation, changing worldview, or compliance. And this is very important. So MF technology can be a persuasive technology. So this is a definition by the WHO of eHealth. It's a medical and public health practice supported by mobile devices. And by networking, by messaging, by educational, by gaming, this technology can generate new ways to increase patient empowerment for self-management and adherence to therapy, as well as to monitor behavioral changes. Why this is important? Because through mobile devices and health-related application, is it possible to empower individuals, but also physicians, in order to create this connection of shared decision-making, which is done by the team of a doctor and patient. And this is particularly important in patients with chronic disease, which actually are a big number. In the US, there are actually 100 million people or patients with at least one chronic disease, over 350 million people US population. So it's a big number. And as well as prevention strategy for us that luckily maybe we are not yet chronic patients, but we will be, because our lifespan is expanding. Everybody of us, if we are lucky, if we arrive to that point, will be a chronic patient. Sorry to say, but this is what it is. So we say that apps and smartphone can be persuasive technology. Let's look at if these persuasive concepts are already inside the design of apps. And I'm here referring to a study that examined the top-ranked 200 apps screened for physical training, physical, motivational, fitness. So we're not talking about medical application, we're talking about wellness. And they were, in this study, classifying the behavioral techniques used in the app, using a taxonomy for this. And what they found is that a median of 4 behavioral change techniques were included in the apps. And here you have a list. And fundamentally, 50% of them were focused on physical activity motivation, so more in the engagement part, if you remember my definition on engagement and enablement. And the other 50%, 46, were focused on physical activity education, so more into the giving the skills and ability, not giving the motivation. But actually, what appeared interesting here and surprising was that action planning, which is considered one of the main behavioral techniques in order to go from the decision to the action, was present in only 4% of his application, which posed a question on if this concept were thought in the design process of an app. In another study, more recent, 2016, they tried to see if the studies that were this kind of a review analysis, to see if the studies published showed effectiveness in intervention. And actually, it was shown that in 19 over 27 studies, these app-based interventions, which include SMS, phone coaching, emails, were more effective in improving sedentary behavior. So again, we are talking about wellness and fitness. And they found that this approach through apps were more effective compared to web-based approach, which was before the standard one. So there is a potential in apps in changing behavior, but also there is kind of a lack of knowledge how to make and exploit this at best. Probably in other fields like marketing, these behavioral change theories are implemented at maximum in order to make us buying things, services, or you just think about when you surf a web page, and after you find advertising on your whatever page you're reading because of cookies, because they know exactly what we are searching for and they are providing solutions. So why this doesn't happen for health? So let's take a look to the patient side, not anymore of the well-being. So why this approach can be potentially useful? This is a common chronic patient scenario. Every blue dot represents 1 hour of a year, and the red dot represents the hour spent with your physician in 1 year by a chronic patient. So it's only 1 dot. If you're lucky, there are 2 or 4 dots every 3 months. Okay, this is the time you have conventional follow-up visits when you are a chronic patient. All the other dots, nobody sees you. So what are the potentials here? The potentials are in self-tracking. You can measure yourself in all the blue dots. You can increase, in engineering we say you can increase the frequency of sampling of your data. And also adherence to treatment. Why adherence to treatment? Because medication non-adherence is the biggest problem of medicine. And occurs in, just talking about cardiovascular disease, in more than 60% of patients. And patients with hypertension, more than half of them are not controlled as they should be. 2 days ago, I was in Estonia. I was talking with the vice president of Servier, which is a big pharma group. He was telling me, we potentially have 8 million euros prescriptions. We get only 4 million euros, 4 billion euros money, because the other half is not sold, because patients interrupt the adherence, interrupt the drug medication, they don't take medications as they should. So, just to make you understand of the problem. If you solve the problem, you become rich, first, and second, you have solved a lot of problems in a lot of diseases. How apps can try to comply with this? This is an example of an app that was developed by the European Society of Hypertension in collaboration with the Italian Society of Hypertension. It's just a simple app that gives you information about hypertension, about drugs for hypertension, comorbidities, and allow you to simply put inside what you measure with your own blood pressure monitoring system. So you just digit or just slide the bar in order to put your self-measurement. And this is not just the app. They made a platform for the physicians in order to be able to see this data, in particular when you go for your conventional visit. And they make a test for 6 months. They had 2 groups, a control group where they didn't use the app. They just went every 3 months to the physician, and the other group that used the app despite going every 3 months to the physician. And this is the result. So the percentage of patients that were able to achieve a targeted blood pressure, which means less than 140 over 90 millimeters of mercury, was doubled, practically doubled, in the group that was just simply using this very basic method. So, this is potential in these apps, but we have a problem. Apps pollution. This is the main problem that everybody of us probably has tackled today. When you go into the app stores and you start digging or you start looking at it, because what you find at the top are just the top ranked or top downloaded. Doesn't mean they are the top useful for you in particular. So, this is the state of the problem. Greater than 300,000 apps just related to medical or health and fitness categories. And how to guide the user, which can be the patient, but also the physician, or the consumer, if you're talking about healthy people, in get the right one. Is this a new scenario? Well, not apparently. With drugs, we have the same kind of variety of drugs, but we have also an approval for drugs. So you have to demonstrate that the drug is actually at least not inferior to another drug in order to put a new drug on the market. We don't have it for apps. And secondly, usually we have an interface that prescribes us drugs, which is our physician. And also you have a pharmacist that can recommend you some treatment in case if this is not, let's say, of the competence of a physician. Here, this doesn't happen. Here we have complete apomediation. No intermediary that is between you and the information. You have to take care of yourself. And from the side of the physicians, what are the problems on recommending or even prescribing an app? Well, first of all, physicians are not sure about the validity and accuracy of an app, except for apps that are being validated as medical devices. Now there are apps that are already class 2 medical devices. So for those is another story. We are talking about medical device, which this gives a little bit more of, let's say, validity on the app. But in the general, other apps, we are talking about data security and privacy. Is the app doing something with the data that we are doing, we are putting in, except reading all our contacts in our smartphone, if we are lucky only that? Or data quality, as the patient has to put inside the data, are we sure, are we confident that the patient is putting inside the right data? If we have to consider this data to take a decision, it is important that it's a quality data. Data integrity. Are we sure that the data is not modified by some bugs in the app? If I put my blood, how you call it? Blood AB80, whatever it is, in my app, and for some reason this is switched to another blood kind, and this information is used for my medical treatment, I'm going to die. There is also a problem of medical duty for data review. If I am a physician, I recommend you to use an app, then I have a medical duty to see what you put in. All this generate problems in professional liability. And also, lack of specific reimbursement. Who's going to pay me, if I am a physician, in order to do this job, to look at this data remotely, instead of just looking at the patient in front of me? What are the regulations right now? First of all, we have to remind that the rules apply to any apps installed by the user, according if a user in the EU or USA, regardless of the location of the app developer. So if we are in EU, EU rules apply. If we are in US, US rule apply, independent of the provider, the developer. And what are the rules? Fundamentally, we have privacy and security. We have a safety and effectiveness, which is the medical device directive. In red, I put the directives that are going to change in the next years. We have a consumer rights, very important, in particular in US. And we have a notification rule for breaching privacy. So these are the main rules that were done not specifically for apps, but were in general for a lot of things. We say that, in particular, if we focus on the medical device directive, only 0.5% apps are regulated as medical device. And this is because they are really only 5%, or because there are many that didn't go into the process. This is the main consensus from physicians, that apps that are actually not regulated as medical device, failure to incorporate evidence-based content, failure to rigorous testing, and gives false claims. And this can take to threat to the user. Is this just philosophy, or we can have a real case scenario? I show you an example. 2014, but we can find the examples today too. This was one of the top 10 downloaded iPhone health apps for some period before this came out. Was, of course, not for free, and it claimed to be able to measure your blood pressure just using your phone with no cuff, without giving any reference to theory that could prove this, any validity, any accuracy. I'm not saying that this is impossible, I'm just saying this was not proved. And if you click on more, and you find written in little characters that this was not a medical device, this was just entertainment purposes. But was this a consumer misleading, potential fraud? The problem is that from the user reviews of this app, people that downloaded and used it, it appeared that these were patients with hypertension that were using these apps in order to modulate their treatment, in order to comply with what they measured. They were trusting the app because they thought, oh, if the app is on the App Store, it's trustworthy. No way. So in order to create a specific regulation, there was, in 2016, a working group on health assessment guidelines was created at EU level with all the different stakeholders involved. In March this year, there was the result. You can download yourself and read the result of this working group. What are the results? Conclusion. Building these guidelines was much more complex exercise than expected. a minimal level of consensus was not reached. It was impossible to achieve and endorse any guideline. This is the crude reality. Why? Because this was like Babel. They were talking about concepts without defining the concept before. Reliability from a healthcare professional has a different meaning than from an industry. So for a healthcare professional, reliability means this app is based on medical results, it complies with guidelines, and so is reliable to use it. For industry, computer scientists is more related to the fact that the software is not crashing. I can use it with no problem. So there was a big deal, and this is the result, which is a problem. So what to do in this no clear, let's say, scenario? Well, general rules that I must suggest is that the most reliable medical apps tend to result from collaboration among developers, physicians, psychologists, and experts in health law, and biomedical engineers like me. I have also to sell myself in some way. The majority of developers have little or no medical training. They don't involve physicians. They are unaware of patient health safety issues due to inappropriate content. Not all apps go through the potential regulatory process, some because they are not aware, some because they don't want, because it costs and takes time. And if you're not paying for an app, you are the product being sold. You're not the user of a service. You are actually the product for somebody else. Think of Facebook. You just put all your picture data information and somebody else is getting the money for your data that you're just putting in. Of course, they give you a service. So how to properly select the best app? As I said, there is no accepted way to do this. There's just some suggestions that were actually reviewed in this paper of 2014. These are valid both from, let's say, physician point of view, but also from the end user point of view. So, of course, not everybody has the digital health literacy to do all these things. And so we go back to the next session. So review the scientific literature. If you find an app that has been reviewed, you know if it's accurate, if it's not accurate, but you have to know how to find this information online. There are some clearinghouse websites that in some way make some certification process. This can be useful in particular if these clearinghouse websites are free and are managed by the state. If they're private, then there is another problem. That somebody has to pay for being certified, and so what are the rules to get the certification is not clear. You can search for app stores to have an idea of what other users have already discovered using the apps. You think it's not the first, these are in the level of suggestions. Review app descriptions, user ratings, and reviews. And here I can add another suggestion, which is also review specialized newsletters. There are specialized websites made by physicians. One, for example, is Mobile Health News. This contains reviews by physicians from a user point of view. So this is better than just common user reviews. And then other things. Of course, if you have time, you can download the app yourself, try it, pilot the app, see how it works, and then finally suggest to patients and see their feedbacks. But we are already in the safe, let's say, harbor here. You really have to be sure that the app you are suggesting is safe and useful. So a potential alternative strategy is something we just attempted. Our aim was to create a filtering tool to assist the user by an automated methodology for extracting a feature. Imagine you can search the app stores based on what you really want, what you really need. So we wanted to test this in a pilot study just to try to use text analytics tools to identify the medical specialty and the type of promoter of the apps. And we focused on the US iTunes Store because we were focusing on English, because test analytics algorithm works better in English. This is how it was, let's say, all this technology developed. And so we screened 85,800 apps. That was the number of English language apps on the medical and health and fitness of December 2016. And this was done automatically with some coding and analysis of the HTML of each web page. Actually, this work was done thanks to my 100 students. This was a class project in which we involved 100 students. Each of them did the job of about 9,000 apps. They were divided in groups, and they focused on a specific letter. Okay, this is how we did. We didn't have any funding for doing this. So, based on that, we built an app database of 66,000 apps. So we removed all the doubling, all the apps that are claimed to be in English, but we are not in English, and of which we had all this information. And then we used a specific tool which is called MetaMap, which is based on the UMLS medical classifiers, in order to search in the description of the app the medical specialties. So if an app is in cardiology, is in neurology, whatever it is. And also we were using some IBM tools of artificial intelligence, Alchemy, which is at the base of Watson, if you know Watson of IBM, in order to try to find other information like the promoter. So who is behind the app? And I just show you the, say, preliminary results that we found. So above the total of apps, 57% of these apps have no specific relation with medical disciplines, besides the fact they were in the medical or health and fitness part of a store. Nutrition was the category with the highest number of apps, 5%, which means 3,000 apps. And for example, cardiology, which is my field, was 1.8% of apps. Well, we had about 1,100 apps in cardiology, at least related to cardiology. And what about the accuracy of this classification? Well, we manually, the students manually analyze 900 apps, randomly chosen, and categorize them according to a medical domain. So we compare this automated classification with the manual one, and the accuracy was pretty good for starting point. So we had 80% accuracy in these medical domains. And the other thing that we found is that only 1% of the apps, so 600 apps, are made, the promoter were government, scientific educational organizations, healthcare providers, publishers, or drug companies. All the other apps were produced by independent developers, the IT super specialized 16-year-old guy in I don't know where in the world, or software houses. These are the majority of the apps you can find. So, to conclude my talk, persuasive technology, like smartphone and apps, have the potential, as we said, and also some literature reports, to change users' behavior, both in prevention or chronic disease scenario. But to become part of clinical practice, several aspects still need to be tackled and addressed by clear rules and laws that goes onto it, also into how you classify the apps, how you make the apps available to the general public, how to avoid that an app can generate harm, how to prevent false claims from app providers. Currently, only apps self-promoted by medical organizations, as the one that I showed you, or approved as medical device, have some chance to be accepted by physicians and then scaled up from pilot to general practice. Test analytics, as we were trying to use, could provide potential filtering capabilities to support patients and their care professionals in informed app prevention. Of course, this also needs to be explored more and improved in a general case to facilitate adoption of this technology. And I thank you. I also want to invite you to this conference that we are promoting. If you have the opportunity to come to Berlin, 9 and 10 of November, and also if you want to take a look to the working group which I chair, the European Society of Cardiology working group, you are welcome to join. It's free. So thank you for your attention.